It's my pleasure to be here, and I'm going to run through some of this kind of quickly so that we have time to discuss maybe some individual cases of things that you face if you're thinking about integrating telepsychiatry into your practices, and try to give you some guidance on doing that. I've been involved for over 15 years with collaborative care, looking at models from co-location to collaboration to integration, and you hear all these terms thrown out there, all these acronyms that are coming out. I'm going to go through some of that to talk about the terminology. But I have to be honest that I shared with a few folks the way that I first got interested in this was when my wife and kids and I were doing a house swap with a family, and we were in Paris for the month, and they were in our house in Wilmington, North Carolina. And I had to come back to Wilmington after 8 days. And I thought to myself, if I could continue to see patients but stay over in Paris, how could I do that? I could spend another 3 weeks with my family, see my patients, and that's when it occurred to me, why can't I do that? In psychiatry, we don't have lots of equipment. We don't have these couches or things that people lay on anymore. Some may, I don't. And so I began to think about that. And as I practiced in North Carolina and became part of what's called CCNC, or Community Care of North Carolina, which is an organization that provided sort of collaborative care models for diabetes, hypertension, asthma, COPD, we did such a great job managing those in one of the early care coordination models in the country. And we did such a good job that they came to me and said, hey, how about you help us do behavioral health? And so it was a challenge because North Carolina is such a rural area in many parts of it, but the challenge was to do behavioral health. And what we found was that behavioral health is not an entity. There are algorithms for managing diabetes, hypertension, COPD, asthma, but behavioral health is a huge multitude of co-morbidities. And that was a challenge. It continues to be a challenge because it's not disease-specific, it's multiple disease states. And so it became clear to me that the only way to effectively manage it is to work together with other people that are trying to manage it. This model of sending someone out on a referral to their specialist is just not a model that's going to work in mental health now or anytime in the future. We have a lot of providers with our institution and our VA. 45 minutes down the road in the counties and the CSBs down there, there's a 9-month wait list to see psychiatrists. Even now, if I discharge somebody from the hospital who's uninsured or has Medicaid or Medicare and try to get them an appointment, they'll get an intake walk-in and see a mental health related person because the insurance company says that I have to provide that, and they do that within a week. But they're not going to see a doctor or nurse practitioner or PA for 3 months. So what happens? They run out of their medicines, they get worse, they come back to the emergency room, they're suicidal, can't sleep, irritable, maybe they've used some cocaine and drugs, and they're right back on our unit and we're cycling back through. We had the record number of patients waiting for assessments in our emergency room last week. 16 unassessed waiting in our large emergency room, which is the second largest healthcare system in the state of Virginia. So telehealth and how we use it is going to be the future. And I also think for many of us too, I'll just throw this motto out there, some stuff that I didn't put in the talk that I want you to be thinking about. Maybe folks that have families that they want to move to and live in areas where there aren't a lot of areas to practice, or maybe if you're retiring, getting older, and you think, well, I want to still practice some. These companies contract with doctors to provide services from your home. We had a child fellow who was working and doing great, and she realized, I can do all this from my house privately and make more money, and she left and did that, and I didn't blame her. Just instead of that option of working as a reviewer for insurance companies and being the doc that calls the other doc in the hospital and telling them that you got to discharge your patient or we're not going to pay anymore, and you argue with them, instead of being that person or reviewing disability claims, nothing wrong with that, doing telehealth provides a much needed service and really focuses on your expertise for patients, and it gets access to them. So think about that as an option for you, yourself, or others in your practice. I want to talk about just the emerging model of telepsychiatry, look at some terminology, and then look at some of the barriers which were talked about last night. No disclosures here. So why telepsychiatry and why now? We have a paradigm shift in how we're delivering healthcare. This is a new time. And as I shared yesterday, my dad discouraged me from going into medicine because of managed care, getting in there and ruining that doctor-patient relationship. I'm kind of like that now. I don't discourage my kids from going into medicine. 2 of them, 4, want to go into medicine and into psychiatry. But I tell them that it's different. You don't have as much autonomy. You have to take some degree of cut in services. You have to be more efficient. You have to be tech savvy. But it's still fun. I still love what I do. As much as I don't like being threatened by opiate-dependent patients on my inpatient unit threatening to kill me if I don't give them opiates that day or benzos, or coming to your clinic and threatening you if you're not giving them opiates or benzos. As much as I despise that, I still love the work, and I still love the healing that goes on in that doctor-patient relationship. But things have changed. We're recognizing that mental health problems are very common throughout the U.S. population. This number that we heard about years ago, 25% of people meeting criteria for one or more major mental health problems. Major mental health problems. I think all of us have some mental health problems in terms of stress, anxiety, sleep trouble. You throw in some high blood pressure, other things onto that, and it kind of makes things worse. 70% of all primary care visits involve a behavioral health problem. That's stuff that gets slipped in at the end, unspoken, and it takes a lot of time. And 80% of those with mental illnesses will visit their primary care at least once in a calendar year. That kind of stuff leads to things like the benefits of screening and screening for substance abuse with the SBIRT, or screening for depression, PHQ-9, GAD-7, brief screening tools. And there are ways to develop those into an EMR, or still doing them on paper in a waiting room and having patients present it to you so that they come to you with some objective data on some of their mental health problems. 68% of people with psychiatric disorders have other medical problems, and most of those folks are going to be seen in the setting of their primary care provider, PCP, internist, pediatrician. There is this big overlap. And those are the highest service users. They use a lot of service. They come into the ER more. They're on more costly medications. So working together to address those problems, the behavioral health, the physical health problems together, not only is great for the patient, but it's cost-saving and reduces burdens on the system. You see the slide here that top 5% of Medicaid members with at least one mental health condition account for 79% of the total health care costs. That is the folks that we're focusing on, and that's who we focused on at the Community Care of North Carolina. High service users in the 4th quadrant with major medical problems and major psychiatric issues. They use more services than anybody else. If that's not an invitation to integrated care, I don't know what is. You treat their hypertension, their diabetes, their chronic pain, and then you refer them to a psychiatrist, refer them to pain management, refer them to cardiology, refer them to gastroenterology. That system is not going to work anymore. No one's going to pay for it, and people are going to get lost in the shuffle, and they're going to end up back in the emergency room right where we started. So we've got to be thinking about this paradigm shift and the finances behind it. Fewer than 25% of people with mental health problems receive minimally effective treatment. So there's a lot of people who are undiagnosed. It takes time, less time to discuss mental health problems. I mean, I'm a busy doc too when I do clinic. I don't sit there and do counseling with people and therapy. I mean, when I first got out of practice, I kind of tried to, but I've learned how to do sort of med check visits where the patient doesn't feel rushed, but at the same time I'm trying to deal with a high volume of people with very serious mental illness that no one else really wants to deal with. We try to focus in psychiatry on treating the top 3% of the sickest people. I spent a year in New Zealand studying their healthcare system, and every single morning I spent with a team of psychiatrists, nurses, social workers for an hour as we went over the list of all the patients referred to us in the previous day, and we had to judge, are they, based on the government parameters, do they fall within the top 3% of the sickest psychiatric patients? And if yes, we could see them. If not, we had to refer them back to their GPs. And I felt like we were sending 97% of people back to their GPs, that we had to do something, and began to set up a network through an electronic medical record for communication between GPs and psychiatrists to give them guidance on how to treat the illnesses. So that was another system that we worked out. There's not a lot of standardized screening, inadequate follow-up, and just no rapid access. Do any of you in your practicing, do you have like a quick psychiatrist or mental health professional that will see your patient right away? Anybody? Yeah, tell us, what do you have?
We have embedded behavioral health in our clinic. We have 2 psychologists, and so we can call them.
Okay. Yeah, and that's in psychologists. You can bill at higher levels than some LCSWs. A lot of insurance panels will pay for psychologists, and so we're using them more in cardiology, bariatric surgery, pre-evals, pain management, mixing them in with our psychiatrists and nurse practitioners and PAs, and they really help provide that behavioral health component. How about anybody to prescribe or give you guidance about psychiatric medication management in challenging patients? Anybody got quick access to that? Or even in our own clinic, we have 8 to 9 week wait lists. So you hear this word silos. The silos aren't working in this new area of integrated care, and sort of what are we going to do? Where are we going to keep the corn if it's not in our silos here? So what are some of the difficulties? 2/3 of PCPs have difficulty accessing psychiatric care, and there's just a severe shortage of providers with inadequate insurance to cover it. Practices are full. There's a problem I'm trying to address now. I've had many family docs say, hey, you take our folks on, but you don't send them back. I'm saying, well, everyone I try to send back, I'm told that you don't manage that illness anymore. It's a psychiatric issue. But you'll treat all their cardiac and pulmonary and pain management stuff, but you won't treat the psych stuff? Why not? Well, let me educate you on how to treat it, because I can't keep them in my clinic. So instead of coming in and, well, we'll see you back in a month, we'll see you back in 3 months, we'll see you back every 3 to 6 months, I do that with the people with severe developmental disabilities and behavioral issues that I have, but I just can't do that for all of the patients. But that's kind of the model we've always had. So I'm teaching the residents and students how to change that mindset and get people back to their patient-centered medical home. The community mental health resources only treat 5% of the population with persistent illness. That's not the place where people need to go. We all like to think that in our counties we have the CSBs, community service boards. They are jammed up with patients, and that's a silo. Why are those patients, particularly the ones that have insurance, why are they going back to a community service board to get treatment for their mental health issues? The model is we shouldn't have people going there. We should have people going to their primary care doctor and getting their mental health care there. But how to do that? And that cohabitation, co-location model, embedded model, has been a model that some have tried to get going. We have it at our Center for Healthy Aging, with a psychiatrist, geriatric physicians, and psychologists, social workers mixed together. But that's one of the few places that we do it successfully. So basically, we have a huge shortage of psychiatrists, and it's not going to get any better. There's a lot of psychiatrists that are aging out and retiring, and it's going to get really bad. A lot of medical students don't choose to go into psychiatry. We're trying to change that. I'm just working on a project now on medical student attitudes towards psychiatry before and after psychiatric clerkships, and having them journal, doing a 1-hour processing. What have they seen? How does it change how they see folks? Trying to destigmatize some of their biases they have. In our med school, it's only 42 students, but it's very highly research focused, so that they have a lot of one-to-one time with attendings and others. Ours, about 15% of that 42 go into psychiatry. We have a big neuroscience research center right there as well. That's very attractive to people. So Where's a psychiatrist in the house? Are you kidding? There just isn't. So if you keep clicking that button or calling and saying, refer to psych, you're going to have to be thinking about other models because it's just not going to happen. And unless we think creatively about that, especially. All right. So the time is right. Resources are scarce. People are inundated with primary care problems and overlapping behavioral health problems, and they need rapid access. So telepsychiatry, I see, is a virtual lifeline. And we talk about primary care integration because we're talking about integrating into primary care, not behavioral health integration. So we call it primary care integration. That's what some of these terms mean, and I want to get into understanding some of that. Some of this terminology is a bit confusing, and so I do hope to clear it up a little bit. We used to hear this term telepresence, just that you could be somewhere in a room. It's more of a corporate model where you see people sitting around, and some are on the screen, and some are in person. They're telepresent, video conferencing. Then there's telemedicine, and that could be texting, phones, all sorts of things to exchange information, e-health, virtual clinics, what we're working on through one of our MyChart within our EPIC build-out. And then telepsychiatry, and that's providing telemedicine particularly for telepsychiatric patients. And it's been one of the most successful platforms because it's been one of the most easy to implement. You see all these terms you get through there. The biggest ones here, patient-centered care. That's what we're talking about. If you send them out to all these different specialists because you don't know how to help them or are concerned, and they have to go there, make another copay, drive there, they're going to get lost. They're not going to follow up, and they're going to become unwell again. So that's not patient-centered. That's just kind of us-centered. I can't handle this. I'm sending them to somebody else. And maybe we can, but we need advice or guidance. That's what consults are about. We can't specialize in everything. If I'm doing ECT on a patient with a dual-chamber cardiac pacemaker, I want to talk to a cardiologist before I do that, or have the patient seen by them, or at least have him or her review the patient's type of pacemaker and whether you need to have demagnetize it before the procedure or not. There's too many types of pacemakers for me to keep up with that technology. I need somebody. I don't need to refer to a cardiologist and wait for that referral, because that'll never happen. That patient will die of depression before that happens. So we got to build in these communication management things. And that's integrated care, coordinated care. How do you work on that? So you see these other terms, co-located care, having two different types of specialists in the same place. That's good if you can do that. There used to be grants that would do that for 2 years, and then they'd run out. Integrated primary care, that's the term we're talking about. Integrating behavioral health, the patient-centered medical home concept, substance abuse, mental health, primary care, all integrated in that primary care model. So here are some of the other terms. I won't spend a lot of time going through them, except that the new types of models are going to be things that come out of accountable care. They've got to be evidence-based and quality-based, and they have to have measurements to say, are these working or are these not working? And that's all falling under this concept of population health. I give you a bucket of money to care for a certain population. You help them stay well. They won't need as many emergency or expensive services. You keep a higher percentage of that bucket. So that if you have to pay for a psychiatrist to telepsych in there, you get to pay for that. That's what you think is best. But you make that choice that the population you're going to serve will get better if you hire a psychiatrist for so many hours or so much availability a week to see your patients. You pay them out of that bucket. You have the choice to do that. If you see a lot of folks with cardiac problems, you can choose to sort of integrate cardiologists through a telepresence, telemedicine, and pay that person so much per day, per month, per week, whatever kind of arrangements you can make to be available to see your patients through a telehealth network when you need them. That's how you keep people well. So that's the new models that we're trying to think through, and it really is something that's going to happen. So where does telepsychiatry fit into all this? It was initially slow to grow because the video conferencing equipment was complex. It was very expensive with a lot of licensing fees, erratic internet connectivity. It wasn't very portable. A lot of people just they just thought, oh, this isn't as good as inpatient, seeing them in person, I'm just not going to do it. They had to get people to buy in. Shortage of people to get to do it once you can get them to do it, and then questionable reimbursement, HIPAA issues. It actually should be HIPAA. So what has driven rapid growth? User-friendly desktops. I was reading today about a product through a company, Kangaroo, that just is coming out with a Windows 10. It's almost like a portable desktop. It's only this big. You can go wherever you want. You plug it into any monitor. You got wireless keyboard, wireless mouse, and it connects to whatever wireless is there or to a Verizon or whatever, and you've got Windows 10 fully capable right there. I've been more of a Mac guy, but I try to go back and forth between the two. But it's a new product coming out next month, trying to get portability. So you don't have to lug around a computer. You can take it and plug it in any monitor anywhere you are. And it's very usable. It doesn't take a long time to upload. So more user-friendly type things. I use Polycom Real Presence in my office and in our rural areas. Video is contracted with Epic, our medical record system. I think having a good EHR is important for communities to network. But I know our organization many years ago spent something like $60 million to buy that. And that's not something most of us can do individually. That's an expensive system. But it's been a great one. And a lot of other hospitals are adopting that. And you can communicate, get records much more easily. And that's sort of, I think, ultimately shared electronic records for mutual patients is just going to be an absolute. There's just no way to communicate about patients in an effective, timely manner without there being a shared record. Getting documents. You admit somebody to the hospital, I might get the records 3 days after I discharge them, faxed to me. That's like writing a check still. My wife writes checks every once in a while. I was like, well, why do you write a check? Come on. They say they only take checks. It's like, no, call them. Go to the website. I feel defeated when I have to write a check. I'm sorry if I'm defending check writers. I just did we just started a mindfulness-based grant. Just finished 4 weeks of a mindfulness training with healthcare providers. That's initial data is very good. We were making something to send out to them, and the lead researcher said, well, we'll produce a CD and send that to everybody. I was like, a CD? Why don't you make an 8-track tape for them while you're at it, They were like, what do you mean? I was like, why do you need to make something? It costs money to get that produced. Just send it to them in a file, in a Dropbox file or something like that. And they didn't even know what I was talking about. And I was like, how many of you actually use CDs anymore to listen to music? And a few people did. I was like, no offense, seriously. I'm 50 years old. I haven't used a CD in 3 or 4 years. I pay a little money for my app, and I can choose any song, any record, anything I like, anytime, anywhere I am, and save it offline and play it later. Jazz, all sorts of stuff. It's not that hard. I usually have my 10-year-old teach me how to do that kind of stuff. When I have problems with my phone, I give it to him, and he fixes it on there. So using friendly stuff and just, I used to use GoToMeeting, VC, Cisco, WebEx, all that stuff. There's lots of programs out there. High-speed connectivity is one of the harder things in some rural areas. And I think states and state legislators need to take the lead in providing high-speed access to rural areas. I don't think that rural areas and local docs should bear the burden of paying to have a T1 line or some other type of internet line to come just to their office and pay a lot of money for that. That's a lot of places. It's just not that expensive anymore to do that. But the further you run that cable, the less bandwidth and speed you can get across it. So I think states need to take the lead, as they did in Mississippi, which Christy Henderson talked about, to say we are going to prioritize this. We are going to make this part of our budget to pay for the connection towers and software, hardware to make that happen for the people in our rural communities. And I would say every state needs to do that. So different types of things that you could do. Portability versus a wireless connection. I insisted in our rural clinics that we be able to have wireless mobility, iPads that are set up. And I'll go through my algorithm, but I see the patient, but then what that does, you don't have to have a fixed room with this equipment. You can't use your doctor's office and put the patient in front of the computer there because there's probably confidential stuff laying on your desk. You don't want to tie up patients in a room waiting because in small areas you only have a couple of waiting rooms. So you can't tie up somebody waiting in front of a TV and tie up a room. So wireless enables that to be efficient and moved around wherever the providers are, wherever the patients are. And we do that with iPads. It could be done with Windows tablets, whatever you like. The shortage has been a problem, and that's why I'm training nurse practitioners, PAs, students, all my residents, all medical students getting familiarity with this technology so they know how to do it. And then there are increasing reimbursement rates, and that's a legislative issue again. State and federal to some degree with CMS. When we do a new pilot in a rural area, the first thing is to check on their rural designation so that we know Medicare will pay for it. And we need to try to work on getting that rural designation taken off for providing a lot of the telehealth services because many of our areas are rural, but they don't fall into the official rural designated shortages area, which is kind of a tight definition. And as more people are getting enrolled in Medicare and Medicaid, we've got to have some of those restrictions taken off to make this work. Better security, ensure HIPAA compliance, and reaching out to distant patients. So 60% of rural Americans live in these designated mental health professional shortage areas, but a lot of them are just around cities and they don't fall into that catchment area. So we can use telepsychiatry to try to reach out to them. Some of the promises that Christy was talking about yesterday in her talk and others, having telepsychiatry in schools so that parents and school nurses or a CNA working, I mean, schools often don't pay for nurses anymore like they used to. So you can kind of maybe have to telehealth into where a nurse is, into where the parent is at work, into where a provider is, and connect them. But that's so doable. It's doable in a matter of a minute. You can get all these people on there. I mean, I do it all day. I just hit a button. We have a virtual waiting room, and everybody kind of comes in, and they're all there. Whoever's talking on the screen, their face comes up. The next person talk, their face comes up, and you can just see people. It's like a dialogue, but it's like you're in the room. It really is. So you can use it, and you can use it for educational resources, for community colleges, teaching providers about mental health seminars during their sort of a lunch and learn for rural doctors and folks. The only people that go to those offices are the drug reps trying to sell you expensive psychiatric drugs. And I believe in doing counter detailing, but we can't just all spend our time driving out to your office to tell you not to give people all these expensive psych drugs. So this is really important. Correctional facilities. They pay very well for psychiatrists to drive in and do that. And currently, at one of our county jails, we have a contract. We have a psychiatrist that goes there 2 hours twice a week to see patients, and we take call when they have problems with detoxes and things like that. We're going to change that over to a telehealth connection. And that's just one jail. We can use the same amount of time and connect to 3 different jails. Nursing homes, ALFs. Just the cost of transporting these people alone is expensive. Exposing them to risk of being around people with infections in the waiting rooms, the surfaces that they're exposed to, the falls risk transporting them. That is a huge problem. It's going to get worse. If we can see them to a telehealth connection right where they are for medical health, physical health, that is the future. Right now, I have 3 psychiatrists and a nurse practitioner that drive to almost 15 different nursing homes to see people at various schedules throughout the week. I say, why don't you do that through telehealth? They say, well, we haven't asked them yet. I say, well, we're going to ask them. That's what we're going to do. because then we can see them 3 times a week or every other week, and much more frequently, without the time of driving over there and back, because some of them are a 30-minute drive. That's tying up a psychiatrist's time. It's just a waste of time. And maybe doing that once a month instead of every week or something, driving in person. Save a lot of time, see more patients. So here are some of the faces of telepsychiatry you're going to see. This is my desktop. I have my camera that'll work on one side and the medical record on the other side, so I can see the record of the patient while I'm talking to him or her. I can type the note or work on that. I often dictate my notes through a Dragon software into the electronic record right afterwards. I would recommend doing that. Saves a lot of time. I used to be one of those guys that went home every night, put on a ball game, got my box of charts out, and just started going through, handwriting my notes. And, you know, that just didn't work. All these kind of things, cell phones, different things, you might think, oh, it's not secure, but actually it is. There are ways to do it and set it up. And if you could talk to patients more quickly, get that stuff taken care of before they come see you, it's much better for them. It keeps them out of the emergency room. I like the idea that we were talking about yesterday. This actually spent an hour today researching that Insight Telehealth, having one of these things that you can drive. I could actually, because we're having problems with consult liaison in our emergency room. Many of our rural hospitals don't have any psychiatric consult service. So what do? They find the medical problem, transfer them to our main hospital under the guise of needing more advanced treatment for that medical problem, then get a psychiatric consult while they're there for a day or two, and then send it back to the community hospital. When I found out that was happening, I thought we could do better than this. We rent one of these things, put it down there. I'll drive that thing from my computer and go just drive around the hospital, wave to people as I'm going by, and go into the rooms and see the patients. Go down to the ER and see folks, because there's people waiting down there too. An ER that might have 5 beds, 1 ICU. They need psych stuff. They can't wait. So we use these kind of things to do that. This is our hospital, the Virginia Tech Carilion, a Carilion clinic. Our medical school's just down the street. We're getting ready to expand a big section off of here, I hope, for a new mental health center, inpatient and outpatient forensics. But we're talking about merging cultures here. Primary care, behavioral health, together, not separately. So there's that consultative model. See the patient in a consult in my office, which we started doing through video networks. It's called a telepsych consult. They call my office, need a telepsych consult. I can do it within 10 minutes. There's that co-located model. Then this collaborative model, which is kind of a blending of things, of people working together. So how do we do it? We do a consult collaboration hybrid. And I'm going to go through the 3 parts of what we did just kind of quickly. The setup, how we do the encounter, and the post-encounter things, so that you can see how we're doing it. And maybe there's things you see that wouldn't work in your office that I'd like to hear about, or maybe you see something that might work for you. To set the system up, we paid a couple $100 for a license for the Polycom, so that we could then just have a desktop icon on an iPad, on my phone, on a Mac Mini, on my computer desktop. You click on that. We pay for the little camera, which I think was a decent one with a microphone built into it, maybe $60. Mounted that in to our system. Since our system has a wireless connection through the hospitals, and that's already firewalled, as long as we're calling into or out of the system, you've got the firewall that you need. It really wasn't that hard, and it really still isn't that hard. So the setup, PCP encounters a patient in the clinic with a psychiatric problem requiring rapid access. Now we say, if it's really rapid and they're suicidal, you call 911, send in the emergency room, something like that. This is not for acutely suicidal patients. Someone's going to hurt themselves or walks in your clinic with a gun, or they're manic and they're all over the office. You call 911 and try to keep them calm. You know, don't call me for that stuff. I'm going to tell you, I'm going to call 911 for you. So this is for the person that comes in. Depression, you've maxed out their Zoloft, you've tried adding in Wellbutrin, they didn't tolerate it, couldn't sleep, still have insomnia, have trazodone, some things you've thrown out, he tried Vistaril, it didn't work. Maybe they are liking the benzos a little too much, and you're a little worried about the fact that they're on Xanax. 3 times a day, 1 milligram, and you're worried because they're still asking for more and says it's not working. Stuff like that. ADHD in a kid, you've tried clonidine, it didn't work. You put them on the Concerta, their appetite went down, they lost 4 pounds, the parents are really concerned. I don't know what to do, you're not sure what should I try next. Bipolar patient with depression, but they have a diagnosis of bipolar disorder, and so you're not sure, should I give them an antidepressant or should I put them on a mood stabilizer? Or what about Seroquel for depression, augmentation, but they're diabetic and have hypertension, and I don't want to do that. These kind of cases that come in that are, most of the time, I'll tell you, 95% of the ones were very appropriate. And these were patients that would have been referred to a psychiatric clinic, but there wasn't one. So we set up this telepsych model, and this clinic is about 2 hours away where we did the pilot. Patients in the clinic, the PCP asks the nurse or care coordinator to get a telepsych consult. That person calls our hotline, so it's a hotline that goes right through. They don't get a decision tree when it rings. My nurses or staff know to pick it up. They get the patient's name, record number, the reason, and the callback number for the person who wants the consult. We insist on a quick conversation between me or the psychiatrist and the provider so we can know exactly what the problem is. Not communicating that through a care coordinator or something, but I need to speak to the provider quickly to know what they want and what the problem is. So I'm notified that I have a consult. I say, yeah, I can see them in maybe 15 minutes, 20 minutes, sometimes 30 minutes. If I'm giving a lecture, it might be an hour. Does that work? And you have the patient go back to the waiting room and I'll see them. We do that. And they put it in my encounter. I'm a separate scheduler, so now I can open the chart. The patient then, when we're ready, is roomed. If I've kept them waiting, I call back and say I'm ready to go. They put them in a room. I dial 6 numbers and have this cool little music, and then I'm in the virtual waiting room. And I can dial in. Anybody can dial in within this secured bridge. I can have a resident with me or dialing in from somewhere else to observe. Right before I do that, I'll call the PCP and say, what's the problem? What do you need? Well, we've tried this, this, and this, and I'll have the record up. I say, yeah, it looks like you've done this and this. All right, let me give it a shot, and I'll call you back. So I conference in, greet, orient, consent them to do this type of thing, make sure they're comfortable with it, and I see the patient. We talk through stuff. In this model, we have the care coordinator staying there in the room if he or she is able to, just to facilitate moving the iPad around or back to the PCP, and prevents an angry patient who doesn't like the fact that I'm not going to give him benzos, keeps him from throwing the iPad across the room and breaking it. At the end, I say, okay, I got some recommendations. Try this. I'm going to have talk to your PCP now. The care coordinator takes that iPad down to the physician, nurse practitioner, whoever it is, and I talk to her right there and say, I've seen the patient, here's what's going on, here's what I recommend. And I use that as that liaison time too, to say, in future patients that come in like this, you might try this, and let's start at this, but then I would probably dose it up to this. If they come back and it's not working, increase the dose. If they complain of this side effects, this would be the next thing you might try. So I try to give them some options, not just say, well, go ahead and increase their Zoloft from 50 to 75 and throw in some Visceral for sleep. Kind of give them more options so that I could teach them about how to handle this without calling us next time. That is the goal, to have the providers I work with feel better at managing behavioral health. And the need for our services at this one clinic with 5 docs went from 5 to 6 times a week down to almost 1 a week. And when I would say, guys, why aren't you calling me anymore? They would say, we just don't need to call. We feel like after 6 months, we know how to manage a lot of this stuff. I was like, that's beautiful. That's what we're going for. Let's go on to the next clinic now. And we kind of go through it. And that's our first of 47 family practice clinics in our rural catchment area. Part of that ends with me telling them what to prescribe. And I don't prescribe anything, sort of a typical consult liaison model. I had one nurse practitioner, and I say, you're going to be the first nurse practitioner in your office to provide Latuda for a patient. I never even heard of that. I was like, well, you're going to hear of it now. Let me tell you about it. I'm not a big Latuda fan. It's expensive, but in some cases you have to do what you got to do. And then they take over providing, and wow, now they're comfortable providing and writing prescriptions for meds they never tried before. And what do they find out? The patients get better. The world doesn't fall apart. They don't get a lawsuit for providing a psych med. And they feel more comfortable the next time providing those medicines. They feel more equipped to care for their own patients. I then do a note very quickly. I dictate my note and route it to them. I bill for my time, usually a 90792 initial psychiatric diagnostic assessment. Use a GT modifier on my coding, which means it was done by Telepsychiatry. They bill for an E&M code. I could bill the same E&M code. And they also can bill a facility fee, this Q3014. And they can bill that just because to do telepsychiatry took a little bit of investment. So every single encounter, they can bill a facility fee. And then I say, if you need me to see the patient again, when they come in again, just let me know. Sometimes I'll say, you know, I'd like to see this patient back in 3 weeks. And we set up a schedule right then to see that patient on the day that doctor's there and I'm available. And we agree to see the patient at that time. It's really been nice. So, you know, you just some of the billing stuff, you enter in this GT modifier after you put in your codes. The family docs enter their E&M code plus this additional facility fee. You know, you get anywhere between $11 and $24 back from Medicare and Medicaid for that facility fee, in addition to your encounter. And I also get paid. So here's other things that you can bill telepsych for. Alcohol assessments and screenings, brief face-to-face encounter about alcohol issues, depression screening, things that are meaningful use measures that CMS knows that if you do a little more time with this, you're going to save money, smoking, alcohol, depression screening. So you can use these other codes and get reimbursed for them. So that's my email. I've got several different emails, but that's one that I'll give you all just because it's easy. trmilam@vtvirginiatech.edu. And I'm certainly glad to answer any questions or share any other experiences about this, but I have really enjoyed doing it. I think a lot of psychiatrists kind of get, you know, we're in our own little practices, our own little worlds, our own little billing worlds. Now we have the same billing codes as you guys. You know, a couple years ago we mandated to do E&M codes, and you thought the world would end in our world, but it didn't. We got away from the 90862, the 90801, and began to use codes like every other doctor. That's called parity. We're still fighting for that sometimes. Sometimes, like if you admit a patient to a psych unit, if you don't get their prior authorization before midnight of the day you admit them, generally you won't get reimbursed. But if it's a medical patient, they don't even have staff on because they can get that the next day. Pediatrics medicine. It's like, well, that's not right. After we look back, we have like almost 3 million in the queue of denials for that kind of stuff. And now we're going back after that money and saying, that's not right that you denied that, but wouldn't deny it for a PEDS case or a hypertension person that came in and you got pre-auth the next day. So utilization management kind of stuff that we're working on. Those things that in private practice just drove me nuts, that I would pay $20 an hour to one of my billing people to go after a $10 claim and she'd be on the phone for an hour and a half. It's like, that's just ridiculous. But you felt like you had to do it because you had to fight. So we still have some fights in terms of mental health stuff, stigma, parity, access. Among geriatric patients, high risk of depression, suicide. The world is a scary place. It is a stressful place for a lot of people. So there's a lot of need. They're going to be coming to the primary care docs mostly for that. And I don't want you to be scared. I don't want you to feel like you just have to refer out. I want you to feel like there's someone that you can call on or access to help you out. We're looking at models of just saying, hey, if you just want to pay for our time for 1 hour a week to meet with 4 of your providers to go through some of your cases with you and say, here's what we got, here's what we got. That's a model that we could do just to help you out. I don't like charging other docs within my own system, so I just do it for free. But that is a model that you could do. In a capitated care model, if you know you can do better care for those people, keep them out of the ER, keep them away from expensive medications, that is a good investment for you. So that's a model that is emerging. Or just saying, hey, we're having a lunch, can you give us a telehealth lecture on the management of bipolar disorder and how you distinguish bipolar from the agitated person? And I'm scared to put them on an SSRI because I'm going to make them manic. You know how many times I put a person on an SSRI and made them manic who had bipolar disorder? Less than 5. And 3 of those were using cocaine and didn't tell me. It's just not that common to switch people into mania. People ask a lot of family docs, what's the biggest risk with antipsychotics? Oh, tardive dyskinesia, dystonia. It's like, how many of those have you actually seen? Or neuroleptic malignant syndrome. How many have you actually seen? Most people, oh, not that much, less than 10. Probably same with me, doing this 15, 20 years, less than 10. How many people have we made obese and have type 1 and type 2 diabetics and caused metabolic syndrome and taken 10 years off their life because of our antipsychotics? Lots. But we don't worry about that very much. Well, we do now. The next lecture is going to be obesity, and it's an important issue. So we've got to work on these kind of integrated models. So it's cool stuff. I get jazzed up about it. What kind of questions y'all have out there? What are your thoughts as
Tom,
you're hearing
that's
this?
an excellent talk. That's just, it's amazing that the way you're able to do that.
Thank you.
Any questions? And if you do, go to the microphone so those that are listening in can hear too, if you would.
Or else I can repeat the question.
Okay,
if
that'd
you
be
speak
great.
up, sure.
That'd be great.
The retired physician who wants to do the telepsychiatry.
Mm-hmm.
For instance, I did primary care for 36 years. But everything I tried to do involved practicing medicine. Because of the insurance and licensing problems, I wasn't able to do. So how do you work around that? How do you work around that issue?
Yeah, most of these kinds of companies, like American Well is a big one, Teladoc. I mean, if you just sort of do a Google search of whatever your specialty or primary care practice is, and type family medicine, telehealth, and then the state you're in or whatever, and look at some of those things. These organizations will get you licensed in states where they have needs outside of your own state, and they pay for that service. They will get you the malpractice and make sure it's covering what you do. They make money off of having you provide skilled expertise to other people around the country. So they will take care of all that for you, and then they sort of send you a schedule and you pick which hours you're available. And during those hours, if someone connects in, you see them, they send you a fee for that, and you negotiate that, anywhere from $90 to $150, depending on specialty, each time you see them. I mean, I think of doing that sometimes, just even with my current job, just I don't know, get a little antsy on vacation with 3 kids after 2 weeks. Let me see some patients, make a little bit of money some evening or something. But it's not that hard, and they are full service. So they're advertising now in a lot of our journals, that they need these folks. So if you look in the back of your journals too, but then doing a Google search for telemedicine, family medicine, North Carolina, and seeing what networks are there, you should have some links right there. And then you call them, and they'll call you, and you talk about it, you ask questions. And they're often glad to have you, and I do think it's a very good way to get some extra income that's good money too, and it helps people. You're being available to people who need it. And they often have caveats. No, you do not have to worry about prescribing benzos or opiates. We just don't do that. And I really recommend that. The Minute Clinics I mentioned yesterday in the Walmarts and Walgreens, the ones in our area, we just completely made opiate and benzo free, so that we encourage people to go in, but they don't go in thinking they're going to get an opiate or a benzo. We just don't even go there. And that's been great for them. It's been safer for them. That can be a big problem. Good question. So if folks are interested in that, Googling your specialty and telehealth and seeing what options there are, increasingly there are more and more companies out there. Other questions, thoughts?
Tom, a couple of years ago, I was at an IHI meeting, and they were using, or showing several different, almost like screening tools for psychiatry, where the patient would click through, and it almost seemed like something for industry, but you would click through these various screens that would talk to you, and then it would ask you questions, and then the person would kind of lead themselves through this thing. Mm-hmm. And then at the end, depending on which direction they went, I mean, it was more psychology, I think, than psychiatry. But do you see that? Or?
Yeah, it's sort of like interactive telehealth, and I will say that I am involved with looking at some new initiatives in that, and have some intellectual property rights on how that might play out. Whereas there are not enough psychiatrists, and screening is a big deal. So one of the things we're looking at and getting a grant for is you have a patient that checks in, and you either have a kiosk where they check in, because our new surgical orthopedics and neurosurgery building has just a kiosk where they come in, they check in, put in their credit card for the copay, whatever, who you're here to see, what appointment, and you go sit. You don't have to interact and wait in line. And so we're looking for ways to do that, like people check into our clinic, you give them like a Mac Mini or a little tablet that has the scales on them, and that you see that they're treated for depression, and you click an icon and hand them that. And while they're sitting in the waiting room, they go through some of the scales to help measure their depression, their anxiety, their bipolar, their side effect profile. And they finish that. They give it back, or they give it to the provider. It goes directly to the screen, so the provider and them can talk about that right at the very beginning. It seems like your PHQ-9 score is better. You're not feeling as anxious right now. You're sleeping better. Tell me more about that. And use that evidence. One, you can track it. It's a good metric to show quality, which we're all going to have to show more. But it also fuels the dialogue with the patient. Often, how are you doing today? No, my sister's dog had to be put to sleep, and I'm really down about that. And you feel like you want to talk about that, but you're treating them for something else, and you kind of got to get to that. I do find that some of these encounters through technology, people are more willing to focus on the issues. You might say, well, you're not getting the juicy stuff, the stuff that keeps you going, their kids, their marriages, and I still like that stuff, and I do get that stuff. But you can do that and be efficient at the same time. It doesn't take that much work. I do find that documentation is the biggest thing. And I don't like typing. I'm not a fast typist. I don't type during appointments. But as soon as that patient leaves, I dictate right into my template, and it's done. Not dictate into a software, then does it and sends it back to me, and you have to review it and correct any errors, and then you post it, because it is days later. It's dictated, it's done right then. So, that stuff is not that hard to do. If anybody's interested, you send me an email. I can walk you through some steps on getting that. It really makes the workflow more efficient, and you're not taking a bunch of stuff home every night. So there are new models. Yep.
How about this in Telemedicine form with a group of 30 family physicians and pediatricians? We can't really get psychiatrists in a timely fashion at all. Most of them aren't taking patients. It's one of the biggest problems I have with family physicians is getting psychiatric.
Yep.
Where can we get a group that we can send our patients to a group that can get immediate attention?
Yeah. If you type in telepsychiatry, Tallahassee, Florida, you're going to get some things that came up. The question is, we've got a large practice of 30 family medicine docs, pediatricians, others. How can we get telehealth or telepsychiatry to them, or any psychiatric resources? These are the types of businesses that are emerging, that you will find somebody in your state that offers that, and they will generally say, we have a contract, and we will set up a service to you. We could do it on a per diem, per week, or on an as-needed basis to provide that service. So I like to do it when the patient's there to be available. And so that you have docs that are available. I do a lot of inpatient and consult liaison, so my schedule's a little flexible. That's why I lead our telepsych stuff. It's hard for me to stop a clinic where I've got 10 patients that morning and do a 1 or 2 telepsych visits. So CL docs, inpatient psychiatrists, or people that just want to do it full time, or using residents in training, upper level residents to be available. Those are things we could do in academic centers, but there are private organizations, In Touch, Empathy, IMPATHY. These are companies that American Well, these are companies that have that capability already and can contract with you. I get offers all the time to join these organizations. And I sometimes act like I'm going to just to learn what they're about and how they vet people. But they are available, and there's going to be more of them, and you're going to need more of them. I'm getting ready to do it for one of our own hospitals that has 18 family docs in a building right next to the hospital doing outpatient with no psychiatrists anywhere. They're only an hour from me, and they still have wait lists of 9 months to see psychiatrists. So we're looking at models to do stuff like that. It's actually quite easy to do, and would probably cost us less than $2,000 to get all the equipment and training and everything set up. So it's worth the investment, and I would look into that kind of stuff. And you're always welcome to email me, and I'll help you look into it, because my job is to get primary care docs access and integrated to get the behavioral health care you need. It's going to keep people out of the emergency room, keep them better, and hopefully all of our tax dollars will go down in terms of healthcare expenditures or be routed to things like preventive health care, keeping people out of emergency rooms. Great questions. I think that's about it. We got the obesity talk. I'm excited about that, so stick around for that, all right?
All right, let's give Dr. Milam a hand.